Okay, good morning. So today we're going to start with the neck, the triangles of the neck. There are two lectures on the triangles of the neck. So to start with, let's have some of the surface anatomical landmarks. We have the laryngeal prominence or Adam's apple, and it is anatomically it is called the thyroid cartilage. We are going to deal with the thyroid cartilage and the larynx because it is one of the cartilages of the larynx toward the end of the course. And the important thing about this prominence is that it moves with swallowing, and we will see now why it moves with swallowing. And then below that, there is the cricoid cartilage, and it is located at the level of C6 vertebra. And this level of C6 vertebra, as you will see when you dissect and you study the relations in the neck, is a very important level because at this level, the larynx continues as the trachea, and the pharynx continues as the esophagus. And then above that, above these two surface anatomical landmarks that you can feel in the midline, there is the hyoid bone. And this hyoid bone is considered part of the axial skeleton, and it is unique in that it is does not articulate with any other bone. So it is suspended in its place by a ligament and by ligaments and by muscles. As you can see here, some of these muscles are located above the hyoid bone and connect the hyoid bone to the, for example, the skull here, the styloid process, the mastoid process, or connected to the mandible or to the mouth or to the tongue, and they are called suprahyoid muscles. And the other group of muscles are located below the hyoid bone, so they are called infrahyoid muscles, and they connected to the sternum, they connected to the scapula. One of the muscles connect it with the scapula, and it moves during swallowing. And it is the bone that is broken during strangulation. And if there is any problem that disturbs this bone or the muscles that move the bone, then the patient will have some problems with breathing, speaking, and swallowing. So this is about surface anatomy. Let's talk about the basic plan of the neck. So here, this is a cross section of the neck, as you can see here. And essentially, there are two blocks. There is this block here, which is called the musculovertebral block because it contains the cervical vertebrae. We are going to study the cervical vertebrae in details next lecture. But one thing that you can see here, which is quite characteristic, is that the transverse process of the cervical vertebra has a foramen called foramen transversarium, obviously, and this allows the passage of an artery, which is called the vertebral artery. So this is a characteristic feature of a cervical vertebra. Also, you can see that the transverse process has an anterior and posterior tubercles. And I'm going to come to this point in a moment. So we have two blocks, a musculovertebral block. These are muscles. They surround the vertebrae. They are called prevertebral muscles, although, as you can see here, not all the bulk is not in front of the vertebrae, and some of them are on the side, some of them are behind, but it is called prevertebral muscles, and the fascia that surrounds them is called the prevertebral fascia. It's a very thick fascia. And then the other block here, which is called the respiratory digestive block, because it contains the larynx and the trachea at below the level of C6. It contains the pharynx and the esophagus below the level of C6. So it is the musculovertebral block. In addition to that, this block also contains the thyroid gland, as we will see in a moment, and it is surrounded by another layer of fascia, which is called the pretracheal fascia. Again, the name might be confusing. Pretracheal, it's in front of the trachea, but it's actually, it surrounds all these structures. It is thicker anteriorly than posteriorly, but it surrounds all the structures that I mentioned, and it's called the pretracheal fascia, and it is another part of the deep fascia of the neck. So until now, we have mentioned two names of the fascia of the neck. And then the whole, all of these, the two blocks, as you can see here. This is the vertebral, musculovertebral block and the respiratory digestive block. The whole is enclosed in another fascia, which is this one, and this is called the investing layer of the deep cervical fascia. And actually, it is not only the fascia, but the fascia as it reaches here. This is the sternocleidomastoid muscle. It will split to enclose the sternocleidomastoid. Posteriorly, it splits to enclose the muscle on the back, which you remember the trapezius muscle, the upper fibers of trapezius muscle. So this investing layer splits twice, as you can see it here. So it's like a collar around the neck, and it splits twice to enclose these two muscles, the sternocleidomastoid muscle and the trapezius muscle. And to end the story, there is another fascia here, which is called the carotid sheath. And this carotid sheath, as the name indicates, it contains the carotid system, the internal carotid artery, the common carotid artery, as well as the vein, which is located more laterally. It is the internal jugular vein, and that black dot in between them, between the artery and vein, is the vagus nerve. So all these structures are surrounded by a sheath of fascia. You will not be able to see the sheath in the lab because we have dissected it, but you will find the bunch of the neurovascular bundle, and you will be able to identify the vagus nerve that is located in between and posterior, slightly posterior to the artery and vein. And it is called the carotid sheath. It's like a tube descending down from the skull. So this is the fourth part of the deep fascia of the neck. Now, if you got a little bit into more detail into this musculovertebral block, I want to emphasize one thing here. We have in this musculovertebral block, again, look at the vertebra. This is the body of the vertebra, the transverse process with its two tubercles. To the anterior tubercle is attached a muscle that we have heard of this muscle a lot now, which is called the scalenus anterior muscle. And this is attached to the anterior tubercle. And to the posterior tubercle is attached another muscle. Actually, two muscles are attached, but the second muscle is very small. So the muscle, the bulky muscle here, is called the scalenus medius, and scalenus posterior, which is a little bit smaller than the scalenus medius. So it is not even drawn here. In other words, scalenus anterior is attached to the anterior tubercle of the transverse process of cervical vertebrae. Scalenus medius is attached to the posterior tubercle. And the nerves, that's the spinal nerves, the anterior rami of spinal nerves that leave the intervertebral foramen, therefore, they will find themselves sandwiched between these two muscles. Okay? And these nerves, C5, 6, 7, 8, at least this in the cervical region we are talking, they are going to form the brachial plexus. That's why the roots of the brachial plexus, as we described it before, they are sandwiched between scalenus anterior and scalenus medius muscle. I forgot to have the mask. Okay, and then you will find them, the trunks, you will find them lateral to these muscles. And these muscles and the plexus, they are all plastered. They are all surrounded by this layer of fascia, the prevertebral fascia. And as you can see, if you want to look at these muscles, from the side here, then you will find them posterior to the sternocleidomastoid muscle, between sternocleidomastoid and trapezius muscle. In other words, they are located in what we call the posterior triangle of the neck. Okay, I will come to this point in a moment, but try to remember this cross section, and we will we'll come back to it in a moment. And this is the respiratory digestive block. I already mentioned that it not only contains the respiratory and digestive structures, but it also contains the thyroid gland. And they are all surrounded by the pretracheal fascia. And here we have a nerve, which we have heard of before, the recurrent laryngeal nerve in the groove between the trachea and esophagus. This is the very characteristic location. Whether it is the right or it is the left recurrent laryngeal, it is always located between the trachea and esophagus, and that groove between them. Okay. Now, one thing to be mentioned about the prevertebral fascia, which surrounds the musculovertebral block, is that this fascia has a lateral extension, and this lateral extension goes to the axilla, and as the fascia surrounds the brachial plexus or encloses the brachial plexus, so the brachial plexus would be present in that lateral tube, in that lateral extension of the fascia, and we call it the axillary sheath, which also contains the subclavian artery and the subclavian vein as well. Now, okay. Now, here again, this is a sagittal section. You can see the larynx here, and that is the continuation of the larynx into the trachea. And behind it is the esophagus, which continues from the pharynx. We're going to study this section in details at the end of the close to the end of the course. But what I want to emphasize here in this section and in the horizontal section, that behind this respiratory digestive block, there is a space between it and the prevertebral fascia. This is the prevertebral fascia, and this is the respiratory digestive block. And this space is obviously called the retropharyngeal space because it is behind the pharynx and behind the esophagus. So they call it the retropharyngeal space. And this space communicates downwards. It extends from the skull above, as you can see it here, from the skull, and communicates downwards, goes downwards into the superior mediastinum and the then the posterior mediastinum down to the diaphragm. Okay, so if there's any infection in that space, you would expect that this infection in the retropharyngeal space can trickle down and cause inflammation of the mediastinum, because the spread of infection, there is a facial plane through which the infection can spread. Also, you can see here that the pretracheal fascia, this blue fascia here that surrounds the thyroid gland, is connected superiorly to the hyoid bone. And because it is connected to the hyoid bone moves with the swallowing, then it's going to pull up on the thyroid gland. And that's why a lump in the neck that is related to the thyroid gland, an enlargement, it moves with the swallowing. This is one of the diagnostic features of a lump in the neck. And the lump that is related to the thyroid gland moves with swallowing, while if lumps that might arise from other structures, they will not move with the swallowing. And the thyroid moves with the swallowing because it is in the pretracheal fascia, and the pretracheal fascia is connected superiorly to the hyoid bone. Now, I have just mentioned about triangles, and I said they are located, these with deep muscles, or the scalene muscles are located in the posterior triangle. So how do we divide the neck into triangles? We use this muscle, the sternocleidomastoid muscle. What is anterior to it is the anterior triangle. What is posterior to it is the posterior triangle. So as you can see here, that the posterior triangle is not in fact on the back of the neck, okay? It is on the side of the neck. But why do we call it posterior? Because it is posterior to the sternocleidomastoid muscle. That's it. Okay. Now, you can see here the borders of the triangle. I'm not just going to mention the boundaries, but these are the borders. The mandible is superiorly, the sternocleidomastoid and the midline. And for descriptive purposes, it is subdivided into smaller triangles. So we have a triangle here, which is on the side of the mandible and below the mandible, is called the submandibular triangle. It contains the submandibular gland. We are going to study the contents later on, okay? And so it contains the submandibular gland, salivary gland. It contains submandibular lymph nodes, nerves, vessels. And in the midline, there is a small triangle here, which is called the submental triangle. And then here on the side is the carotid triangle. Obviously, it is called carotid because it contains the carotid vessels, the common carotid artery and its bifurcation, as well as the internal jugular vein, the vagus nerve, and they are all in sheath. They are all surrounded by the carotid sheath. Now, the triangle that remains here, this one, in the middle is called the muscular triangle because mainly it has muscles and these muscles are called infrahyoid muscles. I'm going to talk about them in a moment, but uh, don't forget that the thyroid gland is also located here in this muscular triangle. So all these are subdivisions of the anterior triangle: the submandibular, the submental, the carotid, and the muscular triangles. The posterior triangle, if you look at the posterior triangle now, it is the sternocleidomastoid, and then we have the trapezius. Of course, they are going to meet here at this line, which is called the superior nuchal line. We have studied that when we studied the osteology of the skull. Remember the external occipital protuberance and the midline? If you go lateral to the external occipital protuberance, there is a line, and this line is called the superior nuchal line. This word, this term nuchal, nuchi, it means the back of the neck. Okay, so when you say nuchal, nuchi means back of the neck, and this is the superior nuchal line. And then inferiorly, remember that the trapezius is attached to the scapula, it's attached to the lateral part of the clavicle, while the sternocleidomastoid, as its name, cleido, is also attached to the clavicle, medial third of the clavicle. So this will leave the middle third of the clavicle here bare, no muscle attachment from above. And this is the inferior border of the triangle, the bone, the middle third of the clavicle between the attachments of the sternocleidomastoid and the trapezius muscles. And if you look at it from this side, then we can see these muscles, the prevertebral muscles that I have just mentioned in the section. Okay, so it is floored by these muscles. If we follow these muscles from the front, there is the scalenus anterior, scalenus medius, and then we have the levator scapulae and then the splenius capitis muscle. We are going to study these muscles and dissect them next time. Okay. Today you are going to dissect and start studying the anterior triangle of the neck. Now this triangle, again, for descriptive purposes only, it is subdivided into two triangles, unequal in size. One of them is very small here. It is located between sternocleidomastoid, the clavicle, and this muscle, which is called the inferior belly of omohyoid. Inferior belly. So it's obviously from the name that this omohyoid muscle has two bellies, superior and inferior bellies. This is the inferior belly, and the triangle, the small triangle here, is obviously called the supraclavicular triangle. It's just a small subdivision of the posterior triangle, and the remaining part of the triangle is called the occipital triangle. So the anterior triangle is subdivided into four parts. The posterior triangle is subdivided into two parts for descriptive purposes. Okay. These are the hyoid muscles that I was talking about: suprahyoid, infrahyoid muscles. Let's start with the suprahyoid muscle. One of the muscles that I'm sure that you have heard of this name before is the digastric muscle. And as the name indicates, di means two, gaster means belly, so it has two bellies. Digastric. A posterior belly here, which is attached to the mastoid process, and then there is a central tendon here, and then the anterior belly. This central tendon is attached by a fibrous sling. There is a sling that attach the central tendon to the hyoid bone. Okay. And in addition to that, there is a small muscle just close to the posterior belly of the digastric, and this is called the stylohyoid muscle. And as the name indicates, stylohyoid, it's attached to the styloid process on one side and to the hyoid bone on the other side. It is this muscle, while the digastric is here. This is the muscle with the two heads. And obviously, the digastric muscle is bordering the submandibular triangle, the two bellies of digastric. The posterior belly is always accompanied by the stylohyoid muscle. Not only that, but both of them, they have the same nerve supply from the facial nerve. Okay? And here you can see here the anterior belly. And so the anterior belly is going to form a boundary as well of the submental triangle here. And you can see the fibrous sling that holds the central tendon of the muscle to the hyoid bone. Suprahyoid elevates the hyoid bone. And then we have another muscle, apart from stylohyoid, we have another muscle which is called the mylohyoid. This is one muscle on this side, and this is the other muscle, mylohyoid muscle. Mylo means it's attached to the mandible, so it's mylo. Hyoid, it's attached to the hyoid bone, and that's the extent of the muscle. These two muscles, they meet in the midline in what we call a midline raphe. So they form something like a diaphragm. Remember, like the pelvic diaphragm. And they meet inside in a midline raphe, which is fibrous tissue. You can see here the fibrous tissue, the white line here in the middle, where the two muscles meet in the midline. And actually, they form a border between what is a mouth above and a neck below. Anything above mylohyoid is in the mouth. Anything below is in the neck. And this mylohyoid muscle, you can see its close proximity to the anterior belly of digastric, which lies just beneath it, or inferior to it. And so both of them, they are supplied by the same nerve. The nerve is called nerve to mylohyoid, but it also supplies the anterior belly of the digastric. And this nerve is not a branch of the facial nerve. It is a branch of the trigeminal nerve, a branch of the division of the trigeminal nerve that provides motor fibers, which is the only division, the mandibular division of the trigeminal nerve, which not only supplies the muscles of mastication, but also supplies four other muscles. Two of them are here, nerve to mylohyoid that supplies the mylohyoid and the anterior belly of the digastric muscle. Okay? Now, these are two other muscles, the suprahyoid muscles. I'm not going to talk about them. We are not going to dissect them today. We are going to dissect them when we deal with the mouth, the geniohyoid and the hyoglossus. Now, those were the suprahyoid muscles. The infrahyoid muscles, we have these muscles, they form like ribbons. Very clearly, you will find that in the lab. And so they are called the strap muscles. Collectively, they are four muscles, and their names indicate their attachment. So we have one muscle here from the sternum to the hyoid bone, so it's called the sternohyoid muscle. And then we have another muscle here from the hyoid bone to the omo, which is the scapula, so it's called the omohyoid. And this is the muscle with two bellies, superior belly and inferior belly, and there is a central tendon here. And this central tendon is covered by the sternocleidomastoid, but the sternocleidomastoid has been cut here. So that's why you can see the central tendon. So sternohyoid and then omohyoid. On this side here, the sternohyoid, this superficial muscle, the long superficial muscle, has been removed. So deep to it, you can see two muscles. That the two muscles will serve or will connect, they have the same destination as the sternohyoid. But there is one step in the middle. So the first one here is the sternothyroid, because it's attached to the thyroid cartilage, to Adam's apple. And then from that point starts another muscle, which is called the thyrohyoid, between the thyroid and the hyoid bone. So again, there is a beginning at the sternum and end at the hyoid bone, but this is served by two muscles, not only one. and they are located deep to the sternohyoid. I have just mentioned about the action of the hyoid muscle, the suprahyoid, the infrahyoid muscles. They raise the larynx, and also they can depress the mandible. So they are also depressors of the mandible. We are going to talk about depression of the mandible and the temporomandibular joint, active and passive depression when we deal with the temporomandibular joint, but for the moment, they also help in depression of the mandible. Now, the nerve supply of these infrahyoid muscles, the sternohyoid, sternothyroid, omohyoid, thyrohyoid, it comes from a nerve from the cervical plexus. There's another plexus of nerves apart from the brachial plexus, which is called the cervical plexus. Remember, brachial plexus begins, or the root value is C5, 6, 7, 8 in T1. So what about C1 to C4 before C5? They form the cervical plexus, and this is the cervical plexus. From C1 to C4 here, this will form the cervical plexus, and the cervical plexus will provide branches. One of these branches comes with C1. C1 here will join for a very short distance, it will join the hypoglossal nerve. Remember, the hypoglossal nerve is a cranial nerve, and it is the last cranial nerve, and it arises from the hypoglossal canal. If you still remember the location of the hypoglossal canal, it is just above foramen magnum. Okay, and what is below foramen magnum? It is the atlas vertebra, and between the atlas and the occipital bone or the occipital condyle will be C1. In other words, these two nerves are in close proximity to each other at one location. And so fibers from C1 will be given to the hypoglossal nerve. They will be carried by the hypoglossal nerve for a short distance and then leave the hypoglossal nerve, as you can see them here. So they are not fibers of the hypoglossal nerve. The term that is used in most anatomy textbooks is that they hitchhike with the hypoglossal nerve. They don't belong to the hypoglossal nerve, but they are carried by it for a short distance, and then they will leave the hypoglossal nerve. These are C1 fibers. And then we have fibers coming from C2 and C3, and they will join together and form the loop. Loop means ansa, or ansa means loop. It is the cervical loop, so it is called the ansa cervicalis. So this ansa cervicalis has root value from C1, C2, and C3, and this is how the loop is formed. You can see it here. The sternocleidomastoid has been cut. This is the cervical plexus, and look at the fibers here. The fibers this is the hypoglossal nerve. It gives this nerve, which is from C1. This is what we call the superior root of the ansa cervicalis, or the other name is called the descendens hypoglossae. You will be able to identify this nerve in the lab. And then we have two roots here from C2 and C3. They join, they form the ansa, and here are the fibers that come from the ansa to supply the infrahyoid muscles. This is called the inferior root of the ansa cervicalis from C2 and C3. This is just to remind you about platysma. It is located in the neck. It is a muscle supplied by the facial nerve. And just remember that this muscle in neck incisions, it is usually preferable to suture this muscle as a separate layer, because otherwise, if this muscle remains there and is not sutured, then tension might cause tension on the skin incision, on the wound, and this will result in excessive scar formation. Now, so far about the muscles. Of course, I'm not giving all the details. Many details are mentioned in the slide. I'm giving you the concept. Many details are present in the slides, or they are also present in the lab manual. So if you want more details, you can go to the lab manual or the details of the lecture. Now, in the neck, the arteries in the neck, we have the carotid system. And remember that there's the common carotid artery. Remember the arch of the aorta. It has a brachiocephalic trunk, which gives the right common carotid artery, while the left common carotid artery arises directly from the arch of the aorta. This has been studied before. So they have different origins here. And the pulse of the common carotid artery, which is very important, can be palpated in the neck. It can be palpated in this triangle, in the carotid triangle here. That is the carotid triangle, and it can be located and palpated. You just move your fingers lateral away from the midline at the level of the Adam's apple, and just anterior to sternocleidomastoid, you will be able to feel the pulsations. And here in this triangle, the common carotid artery at the upper border of the thyroid cartilage is going to divide into external and internal carotid artery. And the internal carotid artery has no branches in the neck. It goes straight up. It's like an express bus that's going straight up to go into the carotid canal and to the brain, to enter the cranial cavity. Okay? While the external carotid artery is the artery that has branches in the neck. So these are the branches of the external carotid artery. And you will be able to identify many of them today. Some of the branches are located anteriorly here, some of them are located posteriorly, and one of them is located medially. And the external carotid artery is going to divide in the infratemporal fossa, which you are going to study probably next week or the week after, into a maxillary artery and the superficial temporal artery. You are familiar with the superficial temporal artery from your study of the face and the scalp. And then the maxillary artery will be studied in the infratemporal fossa. You will not be able to see it on the face because it is located deep to the mandible, deep to the ramus of the mandible. Now, the first anterior branch, as you look at it here, it makes an immediate downward turn to go to the thyroid gland. So it's called the superior thyroid artery because there is another one, inferior thyroid. I'm going to talk about it in a moment. And then we have a lingual artery, which obviously the name indicates it is the artery that supplies the tongue. And then there is the facial artery, and you have met the facial artery in the face. It goes into the submandibular triangle and then loops around the inferior border of the mandible in front of masseter and continues the journey on the face. In many of the cadavers, in many of the prosections, you will find that the facial and the lingual artery, they have a common stem, and then they will split later on from each other. Okay, so it's not necessary that you find these three arteries. Some of them, they might fuse at the beginning and then split later on. One of the characteristic features that you will find today when you look for the lingual artery is that the lingual artery has a characteristic loop at its beginning, and this loop is crossed by a nerve superficial to it, which is the hypoglossal nerve. This is a very characteristic relation that you are going to see today. Then from the posterior part, we have an occipital artery and a posterior auricular artery. And from the medial part, we have an ascending pharyngeal artery. Difficult to dissect, but maybe you can find it. And the other two arteries are, maybe you will find the occipital, but it will be difficult to find the posterior auricular artery. Here also you will find the distension at the beginning of the internal carotid artery, which is called the carotid sinus. This distension might also extend to affect the distal part or the end of the common carotid, but usually it is in the internal carotid artery. It's a baroreceptor that is supplied by the glossopharyngeal nerve, and there is a small body here at the bifurcation, at the level of the bifurcation. Again, it will be very difficult because it's like the tip of a pin, very difficult to find. It's called the carotid body. So we have a carotid sinus and a carotid body. The sinus is the distension in the wall, and contains baroreceptors, and the body is like a small seed of grain, very small, that contains chemoreceptors. And they are both supplied by the glossopharyngeal nerve. The other artery that contributes blood vessels to the neck is the subclavian artery. We have studied the subclavian artery before, remember? Again, it has different origins from the right and left. And we have studied that the subclavian artery continues as the axillary artery and then becomes the brachial artery. Also, we have studied that the subclavian artery provides the internal thoracic artery, which is on either side of the sternum. But this is not the only branch of the subclavian artery. The subclavian artery has a very important branch that you are going to dissect next time when we deal with the posterior triangle, and this is the vertebral artery. Look at the vertebral artery here. It goes into the foramen transversarium of the cervical vertebrae and then enters the foramen magnum to supply the brain. It's another source of blood supply of the brain. And then they will meet together, these two sources, in what is called the arterial circle of Willis, which the details you are going to study in neuroanatomy. And then we have another important artery here, which is called the thyrocervical trunk. Thyrocervical, as the name indicates, thyro, this trunk provides an artery to the thyroid gland, which is the inferior thyroid artery. Remember, I said there is a superior thyroid artery here. This is the superior thyroid artery from the external jugular, and the inferior thyroid, this one, comes from the thyrocervical trunk. It's called thyrocervical because it supplies the thyroid gland, and cervical because it sends other branches. Here we have the suprascapular, transverse cervical, ascending cervical, other branches, which contribute to the blood supply of the neck. The veins, we have the jugular veins, but remember there are three jugular veins. We have the internal jugular vein, that is the continuation of which sinus in the skull? Which venous sinus continues as the internal jugular vein? The sigmoid sinus, okay? The sigmoid sinus continues. This is included in today's lecture, today's quiz. So the sigmoid sinus continues as the internal jugular vein passing through the jugular foramen, and it is located within the carotid sheath. But in addition to that, we have the external jugular vein. This is the vein that in some people, when shouting, or it will pop out. It's just beneath the skin. It's a cutaneous superficial vein. It's called the external jugular vein, as its name indicates. And in front of the neck, there is a group of veins, plexus of veins, which are called the anterior jugular veins. The anterior jugular vein, as you can see, on each side will join the external jugular and they open into the subclavian vein. The subclavian vein joins the internal jugular to form the brachiocephalic vein, which we have studied that when we dealt with the thorax. In the neck, we have the vagus nerve as well, the 10th cranial nerve that leaves through the jugular foramen. It has several branches. One of these branches is the superior laryngeal nerve. This is the superior laryngeal nerve here, this one. And as you can see that it divides into an external laryngeal and internal laryngeal. I'm just passing rapidly because the details are going to be studied with the pharynx and larynx. But we are going to see these nerves today, okay? So this is it's called superior laryngeal and divides into internal, which disappears because it passes through a membrane here, which is called the thyrohyoid membrane. And then there is another one, which is called the external laryngeal nerve that supplies a small muscle here, a very small muscle. It's not a strap muscle. It is a muscle of the larynx, and it's called the cricothyroid muscle. This is supplied by the external laryngeal nerve. And then we have this famous branch, the recurrent laryngeal nerve. Why I'm mentioning the recurrent laryngeal nerve here in the neck? Because uh, well, ultimately it ends into the larynx. It supplies the muscles of the larynx. And because the right recurrent laryngeal nerve, in fact, loops around the subclavian artery, which is present in the neck. It's not like the left recurrent laryngeal nerve that recurs around the arch of the aorta and the superior mediastinum, as we have studied that before. The other structure that you are going to see today in the neck is the thyroid gland, and the thyroid gland looks like a butterfly. It has pear-shaped uh, lobes, two lobes, and they meet in the midline in a narrow part, which is called the thyroid isthmus. And this is related to the trachea, the second, third, and fourth tracheal ring below the cricoid cartilage. In some of the thyroid glands, and we have many of them in the lab, there is an accessory lobe here, which is called the pyramidal lobe, an extra lobe. It looks like a pyramid, and it continues with some fibrous tissue and muscle fibers continues with the hyoid bone. And if you have studied embryology, you will you should know that the thyroid gland actually develops on the back of the tongue and then descends down. And so this is the track of its descent. Sometimes it remains, and sometimes it remains as a cyst, which we call it the or a duct, thyroglossal duct, which results in a thyroglossal cyst. I hope that you have studied that in the embryology. Yes or no? Yes. Okay. The enlargement of the thyroid gland is called goitre, and because the thyroid gland is enclosed in the pretracheal fascia, then when you see a lump in the neck, you will immediately ask the patient to swallow and look at the lump moving up and down, which signifies that this lump originates in the thyroid gland, more likely that it arises from the thyroid gland. The thyroid gland, if you look at the section here, I'm going back to the section, it is in very close proximity to the respiratory and digestive passages. So when it enlarges, it will compress on these passages, and the patient might have dyspnea, shortness of breath, and dysphagia, difficulty in swallowing, because of this proximity of the thyroid gland to the respiratory and digestive passages. And behind it, there are small two pairs of parathyroid glands, may be difficult to find in the lab, but they are located behind the thyroid gland within the same pretracheal fascia. And when they remove the thyroid gland for one reason, or especially if it is benign, when they remove it, they will retain the posterior part of the thyroid gland so that the parathyroids will remain there. They don't need to replace the hormones. The thyroid arteries have just been mentioned. There is the superior thyroid from the external carotid, which you will be able to dissect today. The inferior thyroid comes from the thyrocervical trunk from the subclavian artery. But just keep in mind that sometimes there is another artery, not always present, only in 10% of the cases. It comes directly from the arch of the aorta, and it's called the thyroid imma artery. Thyroid imma artery. This should be kept in mind because you can see the close relation of this artery to the trachea here. And sometimes you might need to do, or surgeons might need to do, an opening in the trachea, what we call tracheostomy, to pass a tube into the trachea. If there is an obstruction to the larynx, so they pass a tube into the trachea directly. And it should be always kept in mind that this artery is there. Otherwise, the bleeding will come from veins, which are inferior thyroid veins. And as you know, that the venous bleeding is easily controlled. So there is no problem if there is a venous blood. But the problem is that with the squirting of the arterial bleeding, not always present, but should be kept in mind that this artery is there. These thyroid arteries, whether the superior or the inferior, they are in close relation to nerves. Close relation to nerves, branches of the vagus nerve that supply the larynx. And therefore, in operations of thyroidectomy, removal of the thyroid gland, where you have to tie and cut the arteries before removal of the gland, then the surgeon should be careful not injuring the nerves. So the superior thyroid artery here is in a close relation to the external laryngeal nerve, which supplies the cricothyroid muscle. And the inferior thyroid artery here is in a close relation to the recurrent laryngeal nerve. And by the way, the recurrent laryngeal nerve, as we are going to study that later on in details, the recurrent laryngeal nerve supplies all the intrinsic muscles of the larynx except the cricothyroid, because the cricothyroid is supplied by the external laryngeal nerve. So there's danger of uh, uh, involvement of or affection. The sound might become hoarseness of the sound, shortness of breath, because the vocal cords will not be able to move. This is motor supply, okay, in addition to the involvement of the sensory supply of the larynx. The veins, we have a superior thyroid vein, which accompanies the superior thyroid artery. We have a middle thyroid vein, which is not accompanied by an artery. And we have a plexus of inferior thyroid veins. Again, these inferior thyroid veins are located in the front of the trachea. And if they are injured during tracheostomy, that's not a big deal. But the problem is with the artery. And as you can see, it is not a single vein. It's a plexus of veins, and they usually drain into the brachiocephalic veins, especially on the left brachiocephalic, which crosses the midline. Now, in the posterior triangle, the other nerve that we have here is the phrenic nerve. You have studied the phrenic nerve before, and so now, if I am going to talk about the phrenic nerve, I'm going to say that it is a branch of the cervical plexus, because it is C3, C4, and C5, mainly C4. And so C3 and C4 are from the cervical plexus, and the nerve, as you will be able to dissect next time, passes downwards vertically on scalenus anterior muscle. So in the front of scalenus anterior is the phrenic nerve. Behind the scalenus anterior, sandwiched between scalenus anterior and scalenus medius, is the brachial plexus. And then we have the branches of the cervical plexus, the cutaneous branches of the cervical plexus. Here they are, 4 of them. We have the lesser occipital, the greater auricular. This greater auricular supplies part of the skin of the face. Lesser occipital passes behind the sternomastoid. Then we have the transverse cervical and the suprascapular. So they diverge from each other in this manner. All of them are cutaneous branches from the cervical plexus. And there is one point here, which is called the point of the neck, where these nerves, they diverge from each other. It is located midway and at the posterior border of the sternocleidomastoid muscle. And it is at this point, if you infiltrate a local anesthetic there, then you are going to block all these branches together. This point is located a little bit higher than the point where the accessory nerve will enter the posterior triangle of the neck. The accessory nerve is the 11th cranial nerve. It leaves through the jugular foramen. Remember, 9, 10, and 11th cranial nerve leave through the jugular foramen. For a short distance, it will find itself in the carotid sheath, leaves the carotid sheath, goes backwards, enters into the sternocleidomastoid muscle, supplies the sternocleidomastoid, and then leaves the sternocleidomastoid at the border between the upper third and lower 2/3, and you will find it in the posterior triangle to reach the trapezius muscle and supply the trapezius muscle as well. This accessory nerve is also the official name of this nerve is called the spinal root of the accessory nerve. And the details you are going to have in neuroanatomy, because this accessory nerve, as you can see here, has a root that comes from the spinal cord, from the upper 4 or 5 segments of the spinal cord. And the fibers will ascend up through the foramen magnum. It will meet a cranial root that comes from the medulla oblongata for a very short distance, and then the cranial root of the accessory nerve is given to the vagus. And what remains of the accessory nerve is only the spinal root of the accessory nerve. So that's why they call it, when you see it in the posterior triangle, it doesn't contain cranial fibers. It's only the spinal fibers. That's why it's called the spinal root of the accessory nerve, because the cranial root of that nerve has already given, or was already given, to the vagus nerve, and serves with the vagus. This is the sternocleidomastoid muscle. So as the name indicates, sterno from the sternum, cleido from the clavicle. You can see that the sternal head is a little bit rounded, the clavicular head is a little bit flattened, and it's attached to the mastoid process. And so the muscle can flex the neck and at the same time extends the head. Okay, like peering over someone's shoulder on the crowd. That is, if the two muscles are working at the same time. If only one muscle is working, then it will flex the neck to one side and rotate the chin to the other side, as if you are looking under a table. This is if one muscle is working. And this is to show you how to test for the integrity of the spinal root of the accessory nerve, because the accessory nerve supplies these two muscles. So you can ask the patient to turn the face or the chin against resistance to test the sternocleidomastoid muscle. And also you can ask the patient to shrug the shoulder against resistance to test the trapezius, the action of trapezius muscle. Thank you very much.